Bismillahirrahmanirrahim. Assalamu alaikum. Welcome everyone, and thank you for joining us in today's webinar. First of all, I want to present myself, Dr. Manal Nasser, lecturer in Karbala Medical College, University of Karbala, specialist in obstetrics and gynecology. I would like to start this meeting by acknowledgement our thanks and gratitude to all of those who have done their best to help the world get through this pandemic and continue to do their vital work at great risk. And remember and cherish all our colleagues who have sadly lost their lives fighting this virus. God bless their souls. As health scientists, we are gathered here to discuss the updates on COVID-19 disease in pregnancy, which we are deeply concerned about its impact on global health and well-being. Dear audience, I'd like to welcome all the speakers in today's webinar. And first of all, I would like to introduce our Dean in Karbala Medical College, University of Karbala, Prof. Dr. Riyad Daihud Az-Zubaidi. Welcome, Dr. Riyad.
بسم الله الرحمن الرحيم وصلى الله على سيدنا محمد وآل بيته الطيبين الطاهرين. كل الترحيب بالاستاذنا الكبير دكتور رحيم، دكتور علي، ودكتور علي محسن، وزميلتنا دكتورة آلاء ودكتورة منال، دكتورة ميسون، السادة الكبار، وكل السادة الحضور اللي يشاركونا في هذه الورشة. معنا الورشة بين المتحدثين والمستمعين. كورونا تحدي للعالم كبير، تحدي أثبت شاشة النظم والبنى التحتية ما موجود في الدول، وبنفس الوقت راح يكون هو نواة لتغيير وصيرورة كبيرة في العالم، تغيير في العالم، تغيير في سياساته، تغيير في حدوده، في القوى النافذة به، وبنفس الوقت هو لربما يشكل نعمة، لربما، لأن الدول العظمى، الدول الكبرى، الدول بصورة عامة بالعسكرية، بالنظام العسكري، لازم أكو عدو. الأعداء هي تخلي الناس الأمم متحفزة. فأعتقد كورونا كعدو، يعني عدو هم شديد الوطأ. أعتقد ما بعد كورونا راح تحدث تطورات كبيرة في نوع الدراسة، في نوع المعالجة، في نوع العلاقات اللي راح تربط المؤسسات الصحية بالمجتمع. أعتقد المستقبل راح يعني يثبت هذا الكلام. أنا أساتذتي يعني في غاية الامتنان من دكتور رحيم حافظ والدكتور علي. أنا اسم دكتور رحيم مرتبط بذهني أنه عراقي شريف، دكتور علي أظن يجي للبلد مو خطار، ما يجي يشوف أهله، يجي يخدم أهله ويعلم ناس. فكثير تعلموا من عنده، ورش كثيرة دخلوا بها أساتذة من كليتنا وزملاء من دوائر الصحة. فإحنا في غاية الامتنان من دكتور رحيم وغاية الامتنان من دكتور علي، وأنا في غاية الامتنان من دكتورة منال ناصح ودكتورة ميسون على جهودهم. كل من حضر اليوم يشرفنا. وايضا من الوصول ان نتقدم بالشكر الجزيل لشركه اسينو للجهود اللي قاعد تقدمها وفي خدمه الناس. انا ما احب اخذ من وقت، اتمنى التوفيق للجميع واتمنى الاستفاده لاخواني المشاركين في الورشه. شكرا جزيلا.
شكرا جزيلا لك دكتور رياض. Thank you very much. The first speaker today is Dr. Ali Al-Naqash. It is MBC, HB, FRCOG, DRCOG, and consultant in obstetrics and gynecology fertility specialist in University Hospital in London, UK. Welcome, Dr. Ali.
أهلا مرحبا. بس حبيت البرزنتيشن هيدا، بس البرزنتيشن عندك.
Please.
Yeah,
please.
Thank you very much, everybody. Thank you for all people listening right now to us, and we miss you all really. And this topic now becoming really a major topic, and we all, to start with, we didn't really think is going to be that serious, but every day this virus is behaving in very kind of elusive way. So let me just start now. It doesn't allow me to go to the next slide. So coronavirus, the COVID-19 is the scientific name, and the other name for it is called SARS-CoV-2. We all know it's first started in China in a city called Wuhan city, and that was in December last year. And then we thought it was a Chinese issue. And then suddenly from China went to every place in the globe, you know. I remember I was in Turkey in February. I can see so many Chinese people, tourists there, and they were not wearing masks and everything. So look, this is part of the reason why this a huge spread of the virus. And the corona, in fact, is the big family, is a family of thousands of viruses. And this is the latest son of this big family. And the coronaviruses, viruses which inflict not only animals, but human beings. And in the recent past, we all heard about the SARS virus and the Middle East respiratory syndrome. And people think this virus is just a descendant of the other before it. The other before it, you know, they were kind of more serious, but this virus is peculiar in one thing, which is the funny behavior first, and the second is most of the time is very contagious. And some people say it's like a biological microbes. Next slide, please. So this is the way it looks, the coronavirus. You can see, I'm pretty sure you've seen these pictures. It's an RNA virus. And these spikes at the surface, they are the main weapon of the virus. This is where the virus attaches itself. These spikes, I read a whole paper just talking about these spikes alone, a whole paper. And this spike attaches itself to the surface of the cell, and then there is fusion between the membrane of the spikes and the membrane of the cell, the human cell. And then suddenly the virus will go inside the cell in a process called endocytosis. So then go straight away to the nucleus, because it's an RNA is going to change itself into DNA and going to merge itself into the DNA of the cells, and then enslave that cell. So that cell become slave for the virus. It's going to generate the virus again and again and again. And when it's full of viruses, this cell would burst, would die, and the virus go ahead and inflict another cell. Next slide, please. So coming back to our subject, pregnancy and COVID-19. Are a pregnant lady more vulnerable, more susceptible to the virus? It doesn't look so, even though there was some study published recently from France. It's a small retrospective study about 50 odd patients. Haider, next slide, please. So this study is published early this year in the American Journal. And that French study has shown that in some of these pregnant ladies infected with corona, they have increased morbidity. They have increased risk of a preterm delivery. And then in that small study, nearly half of them, look at the percentage, 43% of them required invasive mechanical ventilation. So 43% of this cohort of patients, pregnant ladies with corona, they needed to go to the intensive care unit and have ventilation and intubation. Next slide, please. So corona and pregnancy, I think this slide is now well known to everybody of us. We all read it day and night, the way the virus is transmitted, the way we protect ourselves. And to start with, it's all common sense things: washing your hand, leave the spacing 2 meters away, avoid touching your face with your hands. And then if you want to cough, you have to cough either to the tissue, or even when you sneeze, or cough to your bent elbow, which is, we rarely do this simple stuff. Even myself, my wife keeps reminding me every time I sneeze that to do it like this. But anyway, these are human nature, and this is new habits we have to learn from now on. Next slide, please. What about the baby? What is the risk of the baby being infected with the virus? The Chinese say there is no such a vertical transmission, and that's from their experience with the virus over a 3-month period. However, there are reports that there are infected newborn babies. They could find IgM in the newborn babies. And IgM is a big molecule. It doesn't go through the placenta. So it must be something made by the baby itself after exposure to the viral particle. When that happened, is it from the vagina, in the vaginal fluids? Nobody knows. But I read some report saying that the virus can be detected in the vaginal fluid. So it can be, in a sense, can be sexually transmitted as well. So next slide, please. So what are the symptoms? Well, this is the most pressing issue, really. We all have cough every now and again. We all have fatigue sometime. We all have a sneezing. So because these symptoms are so common, so it's very terrifying, because every time anybody of us have a cough, you think, oh, am I got it, am I not? But it looks like the most common 2 symptoms are the cough, which is dry, and also the fever. The fever could be as high as 39 centigrade, and the cough is usually dry and very annoying. I have a friend of mine, she was a junior doctor. She locked herself into her room for nearly 2 weeks with very, very dry cough, very strong cough. And at that time, that's happened in April, when the crisis in UK was just at the beginning, and nobody knew about the extent of this problem. If you come and look at the other symptoms, like the fatigue, like the sneezing, like diarrhea, like the running nose, like the shortness of a breath, they are not common symptoms. And a very common symptom as well now is very important, not mentioned here, is loss of sense of smell and taste. They say this is very diagnostic. If the patient comes to you saying that I have nothing, I just lost taste sense, that's very diagnostic, very specific of corona. And just imagine, this is a virus. In 80% of the patients, there are no symptoms, or there is only mild symptoms. This is where the risk lies. So when I see these people in the airport checking the temperature for patient, for everybody comes in, trying to detect infected people, this is not very reliable test. Why? For a simple reason, because the infected person can be in the incubation period first. He can be one of the 80% who's completely asymptomatic. Or maybe he had a temperature, or she had a temperature, and then she used some paracetamol, and then she suppressed the temperature. So just to check the temperature for incoming people is very crude and very simple test, not effective at all to me or to anybody who just reads simply about the virus. So next slide, please. So this is a very nice table. It tells you, how do you pick up the cases? How do you know this is not a simple flu? How do you know this is not simple cold? Again, the 2 commonest symptoms are the cough, the dry cough, and the temperature. And when the temperature happens, what happens with it usually, the muscular ache. They go together. So you can see, if you sneeze, this is not a corona. If you have a runny nose, most likely it's not a corona. If you have a diarrhea, it's unlikely to be corona. If you have just headache, which anybody can have headache, it can be corona if you have a temperature of 39, because high temperature would cause headache. And there's something which I found a bit surprising is the shortness of breath. Also is not very common symptom, though most of the people die late, as you would hear from Dr. Rahim when he speaks to you, from the respiratory problems. So essentially most people, when they die, it's because of their chest. But when they present, it's usually they don't have much shortness of breath. If you go to the cold or the flu, it's the other way around. It's the other way around. You have the sneezing, you have the runny nose, you have the sore throat, which is very characteristic. So, and that's the way you're going to differentiate. I think part of the reason of the panic, cold and flu are very common symptoms. And then how do you come to the coronavirus and you know for sure you don't have it? The West has solved this. If they have suspicion about anybody, they just test him or test her. And then we can go to the test. And testing, I remember I saw a picture very early on in April. It was from a picture from Israel and Palestine. They have special small shops on the roads. It's like a small kind of, just for anybody to come in to have a test for corona. And in that case, they're going to test most of the population, and it's totally free of charge, totally free of charge. That's happening in April in Israel. Now, the Iraq, when they started doing a lot of tests, they started picking up many cases. So the panic started. These 2,000 a day now in Iraq, probably it was like that 6 weeks ago, but they were not testing them. So they were not detecting them. That's a problem. And now they are getting detected, then it's coming like a panic. I can see the panic among people. I can see the people thinking, oh, we are not protected. I tell you, 6 weeks ago in the UK, in our hospital, we used to have 10 to 15 deaths per day in the UK. That's where the peak was in London. And at that time, the mortality every day in UK, it was 2,000 a day. So, and still the British, they behave very calmly because they have a plan and they know what they're doing. So the panic right now, I can see everywhere, there is no need for it. There is no need for it because now Iraq is in the peak, yes, but if they follow the rules, the peak should subside. If you panic, obviously, it's not going to work, it's not going to help. But again, you have to have discipline. You have to, I remember when the previous prime minister, he invited the Chinese, the first Chinese when they come in April or late March, the convoy, the Chinese convoy, they have this meeting on the television and all of the Chinese experts, they're wearing masks and they were very serious. And next to them on the other side of the table, here sat the Iraqis, including the ministers, and nobody wears a mask at that time. So that tell you, they, even at the higher level, people did not appreciate the problem. And they thought it's nothing, it's just another flu, it's just another viral infection, which eventually would go away. Next slide, please. So how do we test for it? So there are, in principle, two types of tests. And I'm pretty sure you all heard about it. The PCR, this is in which you detect the gene of the virus. You take swabs, either nasal swab or throat swabs, and then this is an RNA virus. So what does this test do? They add a special enzyme called reverse transcriptase, change the RNA of the virus to DNA, and then they complement this DNA with a certain nucleotide which match it. And these nucleotides are attached to fluorescent material to appears. And they multiply this thousands of times. So if the special nucleotide code set in a place, that's the virus. And they can see it as a kind of illumination, light, yellow or whatever. And this test takes like 3 days. So it takes a long time to do this test. The other test, which is probably could act as a screening test, is the antibody test. I don't know whether you've seen how it is done, but it's like a pregnancy test. Have you seen the pregnancy test? You take a blood sample, you put it there. I heard in South Korea, they have this, you can get yourself tested in a matter of minutes, 10 minutes. But most of the time, even in UK now, if you want to do the antibody test, it would take a day at least, and then you get the result. And sometimes some people before that, even in UK, it wasn't kind of available widely until recently. Because I remember 6 weeks ago, not everybody get tested. You have to really be especially at risk or working in an environment which makes you susceptible. If you phone them and you tell them, I have these symptoms, they tell you, stay at home, do self-isolation, don't come to the hospital, don't come to work. That's what happened to my colleague doctor in April time. Nobody bothered to test her or anything. I'm pretty sure she had a corona at that time, but she stayed in her flat for 2 to 3 weeks. She self-isolated herself. Even her kids were not allowed to come to her. So that's the antibody test. The one in Iraq they do now a lot now is the PCR, which is a kind of very, very accurate test because simply you culturing the virus. You see the virus. And I would come and compare these tests together just on the next slide. Next slide, please, Haida. So again, we have three tests principally. Is the PCR, polymerase chain reaction, is the antigen test in which you direct against the specific proteins in the virus, and then you have the antibody test. And we all know there are two types of antibodies. There is the IgM, which indicate acute infection, like any other infection, when we do it in toxoplasmosis, syphilis, whatever. And the IgG. The IgG, what it means, that you previously infected and now you got immunity. And that immunity, is it going to last or not? That's a different question. People said before, if you get infected, if you have the IgG, then obviously you don't need to worry because that's mean now you are like you had a vaccine or something. But now they think, no, there are cases of reinfection, and there are some report, there are Asian minorities like us, they could get infected and they could not develop any antibodies. That's the problem. That's why so many overseas doctors died here. There are many Iraqi doctors died here, by the way. It's not, and that's something happened back in April. So we go back to the test itself. The PCR, I've mentioned, I talked about it. It's a very accurate test. It takes time. It needs facilities. It needs staff trained to interpret and know how to do it. And I know in Iraq now, there are so many labs available everywhere in all the provinces. It used to be only in Baghdad, but now in every province there is a lab there. And then the antigen test. This is kind of very new, is not widely available. The difference between it and the PCR is even more accurate than the PCR. And the result, you can get it in a few minutes rather than 3 days, but it's not widely available. And then coming back to the antibody test. The antibody test, I don't know whether they do it now in Iraq or not, is a blood test. You check for the IgG and the IgM. Some people underrated and they think this is not very accurate test, we shouldn't do it, But believe me, it's better than not, because if you are working in high-risk environment, like medical staff, working in hospital, it would give you some kind of, some sense of security that if you have the IgG, that means you have some immunity. So you don't need to panic, and of course, you still need to use the usual precaution, the spacing, the mask and all that, but at least you have some comfort that you got the antibodies. The IgM, if we detect it, that's mean you had the infection acutely. Now you are infected. Next slide, please, Haida. So this IgM, IgG test, the serology test, how accurate it is? Some people think it's not accurate at all. But again, look at the studies. If you do it up to 15 days, day 15, the accuracy, it's accuracy like 70%. Not too bad. You can detect 2/3 of the cases up to day 15 or 14. Up to day 35 after symptoms, the accuracy even be higher, 90% of people detected. But after 35 days, the accuracy goes down. So essentially, if you have a negative test that you don't have any IgG, shouldn't give you the assurance that, or you shouldn't be kind of terrified that probably you haven't had it or had it, whatever. So you still can do it as a screening test, and I think it's a much cheaper test. Here, if you want to do it privately, I think you have to pay £100 or something. But again, it's, and anybody now can do it, in fact, and now they relax the rules. All people working in a high-risk situation, like in hospital, like us, they can just go and ask for the test. I haven't asked for it yet, and I don't want to ask for it for some reason, but who knows? And this is a last slide for me. Thank you very much for listening.
Thank you very much, Dr. Ali. It was very informative lecture. And now the lecture for Dr. Rahim Halu, consultant in obstetric and gynecology of RCOG in Basildon Hospital University in UK. Welcome, Dr. Rahim Halu. Yes, okay.
All right, is that clear now?
Yes, let's give it full screen. Yeah, thank you.
Okay, fine, very good. Well, my apology, I'm very sorry about it. I don't know what happened actually. Anyway, we'll go back to the confidential inquiry into maternal death, which identify the death from viral infection and bacterial infection. And it identified that the death from infection is about the 5th cause of death or maternal death in England and Wales. Now, and we know that it's due to viral infection and due to bacterial infection, but we are familiar with the viral infection. But if you look at the contribution of the infection to the maternal death, you will find that the flu used to actually contribute a lot to maternal death in pregnant women. But from 2013 until now, the green line in front of you coming down very, very quickly. And now the maternal death is due to flu or viral infection in the pregnancy is about 0.1 per 100,000 maternity. Now that means very, very low. But why? Why? Because the introduction of the flu vac, which is the vaccination of the flu, all pregnant women in Britain will actually have injections during pregnancy. Now, we know Dr. Ali mentioned a few things about the number of patients and number of very bad cases, and number of patients admitted to the ITU, and number of deaths. And we know that from Italian publication and the Chinese publication, the death rate is actually below 10. But we will mention that later on, because there's a variation between China and Italy. Now, from the beginning of problem in Britain, we identified the high-risk group. And from day one, we said that pregnant women will be included in that group. And that group will contain the people above the age of 70, people with comorbidity, and of course, don't forget the pregnant woman. But why pregnant woman? Pregnant woman because there's an immunological change during a pregnancy. And that immunological change may be a factor which contribute to problem with the effect of the virus and bacteria on the lung function. Now, if we look at the American publication so far, they actually compare the pregnant women with non-pregnant women, and they identify 8,207 with COVID in the pregnancy, and compare it with 83,205 women with COVID, but they are non-pregnant. What they found that if you look at the hospital admission for among the pregnant women, it's about a third of these people, infected people, admitted, comparing to non-pregnant, which is about 5.8. So it's very, very clearly that the pregnancy contributes to the problem. But there are other contributory factors. If we look at the ITU admission double in pregnant women comparing to non-pregnant women. Mechanical ventilation about 0.5 in a pregnant woman comparing to 0.3 of the people admitted to the ITU. Mortality, they are equivalent, about 0.2 mortality among pregnant and non-pregnant. Age factor is very important. Younger age group, between the age of 15 and 24, they are likely to have the infection or admitted to the ITU, comparing to the group of 35 to 40. One important issue about the ethnicity if we look at non-white and white, and you will find that non-white is about 3.5 admitted to the ITU, comparing to 1.5 in all pregnant women, including the white, of course. And they pointed out that the blood group of A more likely to have a problem and more likely to be admitted to the ITU. Now, what about our management? Our management, the cornerstone of our management is the protection of the doctor, nurse, and paramedic. That's very important, because without them, we cannot function. Without them, we cannot help our patient. And then we should actually save the patient and protect the community. Protection of the community, meaning that we are actually cutting down on the number of admission, number of the people requiring ITU management, and number of deaths. Now, if we look at what is the ideal plan of management, what is the ideal plan? The ideal plan, if you have a patient may be infected, then we have to admit her to what we call it, to a negative pressure isolation room, which we don't have. Now, if the patient confirmed, then we have to admit her to the negative pressure isolation room in the ITU, and that's different. In addition to that, in Britain, they actually, like in China, they built a new hospital. Like we in London have Nightingale Hospital. Nightingale, it can actually admit about 2,000 patients in Nightingale. But in that hospital, we have to make sure that people actually have protection. People working there, whatever you are, you have to have protection of the mask, the cover, the head cover, gown, gloves, and everything. That is in order to perform your duty and save your patient. Now, like you are familiar with that picture of covering yourself and protecting from infection. And then we go to the principle of management. What are we actually going to do? What is our principle to manage the patient? Number one, we know that there is no vaccination and no effective medication or drug available to treat our patient. And therefore, we have to have a supportive means. Now, if you look at what happened in 1918, when we have the flu, 18 million died because of the flu. Why? Because at that time, we have no vaccine, we have no treatment, but we have no technology at that time. However, now we don't have a vaccine, we don't have treatment, but we have the technology. And therefore, it will be a general management of COVID-19. Targeting management of the pregnant woman is our specialty, and even that we have to approach the problem like a multidisciplinary, meaning that we have to involve people from other specialty in order to protect our patient and treat our patient. So the government came with the idea of this new terminology, lockdown. Lockdown, 2 meters and hand wash, face cover, avoid touching eye, ear, and nose, and shielding. In the shielding, they actually put the pregnant woman as should actually have to have shielded. Shielded meaning that you have no contact with anybody outside your home. That means they know that this is very, very high risk group. Okay, now what about labor ward? How we actually function on the labor ward? All women are managed as a COVID. Any patient coming to the labor ward, we manage her as carrying the virus with her. And therefore, we have to admit them in addition to taking a precaution like any other, any COVID patient, approved COVID patient. However, if she is COVID positive, then she will be admitted to a corner in the labor ward, and she will be looked after by a midwife, which is not allocated for her only, but not for the other patient. And we have what we call the second team, meaning the team looking after the labor ward and team looking after the COVID patient. And we look at them after them from the team with the multidisciplinary idea. And we have to have a clear indication to escalate the patient to a critical care team, meaning ITU. Now, if we have a patient who proved to be positive, or we think that maybe from her symptom, maybe the COVID, then our aim to avoid a general anesthetic, and therefore early epidural in labor to avoid GA, and if no epidural, of course, we have to go for spinal. Chinese will deliver all patients, not allowing vaginal delivery at all. However, remember that we have a very high rate, as Ali mentioned, high rate of prematurity from the Chinese and from Italian. We have a 50% prematurity in COVID patient. Now, what about general management? We know that general management, ibuprofen, paracetamol. However, if you look at the ibuprofen, at the beginning of the COVID problem, we say that you should not actually have the ibuprofen because it might actually, you might die because of the ibuprofen, but that's all not true. Now we prove that, well, look, you can actually take paracetamol, you can take ibuprofen for headache, for fever, and other things. We recommend the fluid intake and maintaining hydration, and of course, multivitamin and healthy eating, more green vegetable and fruit. These are general things. The main problem and the main issue with COVID is hypoxia, because it's a marker of our problem. The bad hypoxia, meaning that you have a bad problem and the probability of admission to the ITU, probability of dying will be higher. So more oxygen required, meaning that more problem. Young women compensate very well. We don't know why, but we think that they are actually young and they can cope with hypoxia, not with the infection, but with hypoxia. But they can deteriorate quickly. How can they deteriorate quickly? We say that beware of happy hypoxia, meaning what? In an adult, if you are hypoxic, when you actually reach O2 saturation of 90, while in COVID, in a young patient, they can actually compensate very well until they are probably near to 70, which is very, very low. That's why occasionally we have a young patient or a pregnant woman compensate very well, but then immediately she will collapse in front of you, and we don't know why. From a normal coping very well to comatose or collapsing in front of you. So therefore, the issue here, the major issue in our management is the oxygen, and that's very, very important. So we have to learn about that very, very carefully. The meaning of it, how can we give it, and what method we give. Should we give the catheter, nasal catheter, or a mask, or intubation, and the target oxygen saturation, how much? We know that normally we should have oxygen up to 100, but anything between 90, 94, and 98 is fine. And the requirement for that, we need about 2 to 4 liters through the nasal cannula or mask. But of course, we have to monitor them for any deterioration, and that's very, very important. The deterioration meaning that the requirement for oxygen is very high, and therefore, when we have what we call the fractionated inspiration oxygen, if we reach about 40% requirement, meaning that there's a big deterioration, and therefore you need to escalate to the ITU team. Now, what about general support? We mentioned the fluid, we mentioned antibiotic. Antibiotic for a pregnant woman, of course, one known. A patient requiring delivery, we should actually put her on augmentin, normally we use. But we know that we can actually use antiviral, especially the HIV medication. And if we look at the steroid, at the beginning of the infection, we say that there's no evidence of benefit and may be harmful to give because it will increase the viral shedding, but might be considered maybe if you have a problem with the IRDS or cytokine storm. Chloroquine, the WHO said no, forget about it because it's not effective, and the American made a big fuss about it, but now it's actually gone completely. Okay, but therefore our concentration now on the ITU management and the management of the oxygen. Now, the group of people now having like a website trying to collect more information about that virus. Now it's about 198 antenatal clinic involved from different countries. 23 countries contribute to that website. Any patient you have, you can actually report it to COVID-pregnant variable at www.covid-pregnancy.ch. And that's very good because they try to collect more information about that. Now, with regard to the delivery is very important here. If we require a GA for delivery, occasionally we might require a GA for delivery. During intubation, you should be waiting outside the theater for 20 minutes. You should wait before entering the theater in order to avoid what we call the AGP, which is the aerosol, which might actually contain virus. We have to wear orthopedic head cover. We have to wear visor and goggles. And we have to use the FFP3 mask. And that's very important. And you have to have a fitting before wearing the mask. They have to fit you with the mask in order to make sure that there's no leakage. Your gown will be a reinforced gown, and the diathermy you are using should be built with suction during diathermy in order to avoid any contamination of air around you. Pediatrician should wait outside and waiting for the delivery of the baby. And when you finish, you have to remove everything. You have to remove your gown, you have to remove your mask, you have to remove your glove in one area. Now, we have one important thing. Our knowledge about COVID, we thought that it might be only an inflammatory problem affecting the lung cell, but now evolving, and we know now that there's a microvascular thrombi and pulmonary embolism, and that's why we have a very high D-dimer. And therefore, we know that the management of COVID in April, March, April, is different from the management in June, due to the fact that we understand now the pathology or the physiopathology of the COVID is different. So therefore, we have to have a VT prophylaxis guideline. And the guideline very simple. We have to give pharmacological prophylaxis for every patient, depending on her platelet count. And therefore, anybody with the platelet count more than 30, we give her prophylaxis, not a treatment, prophylaxis. But if she requires treatment, we should have a platelet count more than 50. And therefore, we have to check the D-dimer, check the liver function, check the urea electrolyte regularly. If there is a clinical deterioration, then we have to change the prophylaxis from prophylactic VTE to a therapeutic one. And the anticoagulation protocol, depending on two things, depending on the D-dimer and depending on the creatinine clearance, in addition to the platelet count. In a patient with the D-dimer below 1,000 and creatinine clearance below 30, we give the normal dose of Anhexla, which is the lacaglexane injection, 40 milligram, and depending on the weight of the patient. Now, alternatively, if you don't have that one, you can give unfractionated heparin 5,000 units twice daily. A patient with a D-dimer more than 1,000 or creatinine clearance more than 30, in that case, we have to double the dose for the category of patient below 100 kilogram, between 100 and 150, and above 150. So therefore, Inhexna will be given twice daily, and for below 100, and 80 milligram twice daily above 100. Now, but if you have a platelet count below 30, and therefore there's a problem with the bleeding, and the patient requires therapeutic dose, we don't actually give her the heparin or the Inhexna. We recommend the mechanical thromboprophylaxis. It means that we have to put her on the compression stocking, which is electronic one. Now, what about low molecular weight? Low molecular weight indicated only if the patient was already on the novel oral anticoagulation like rivaroxaban. And in that case, we actually change them from that oral treatment to low molecular weight heparin. And don't forget, some people might be actually having a problem with the renal impairment, and in that case, you have to look for the level of the creatinine, and of course, depending on that, you actually give, again, low molecular heparin for this group of patients. Now you are familiar with the British publication about dexamethasone and the value of it, and what they found clearly that the mortality rate and the hospitalization reduced by nearly about 30%. And therefore, you have to think about who is going to more likely to have the dexamethasone. And of course, all the patients actually in hospital and proved to be COVID positive. With radiological problem, maybe radiological finding, and or if they reach oxygen requirement more than usual, like if the saturation dropped to below 92, and some people said maybe 90, then there's a room to give the dexamethasone in order to improve their recovery. Or the patient require intubation, or patient require ECMO. Pregnant women and breastfeeding women with COVID, and they benefit from prednisolone 40 milligrams orally if they can take the oral one, or IV hydrocortisone 80 milligrams twice daily should be used. But we don't actually give it to people outside the hospital. It should be in. Now, the Dexa, as you know, can be given orally by tablets, and they are tablets of 2 milligrams, so 3 tablets once daily, or even we have the fluid, or what we call the oral suspension, and we have intravenous injection of dexamethasone if the patient intubated and cannot take it orally. Duration for patient with indication of giving dexamethasone 10 days every day injection or oral tablet. But remember that with the oral tablet, you have to think about the effect of that treatment on the stomach, and therefore, and of course the blood sugar, especially in diabetic patient, and therefore you have to monitor the hemoglobin A1C in non-diabetic initially, and for diabetic patient you have to monitor the blood sugar 4 times daily. And that's very important actually to make sure that you don't actually treat thing and you create another problem for the staff. Now, what about if you think that the patient might actually have COVID and you have indication that you need to give dexamethasone in order to improve her recovery? Yes, you can actually give the COVID, give the dexamethasone. What about vitamin D? Vitamin D, if you look at the graph here, the bar, you will find that on the right hand side you will find a green column. The green column indicating that if you give vitamin D or 30 milligram to 40 milligram, the probability of having mild form of COVID is very high compared to 2010 or none. Therefore, why the vitamin D protecting? The vitamin D protecting, it might be due to inflammatory, anti-inflammatory criteria or to decrease the inflammation. And it might be effect of the vitamin D on the innate immunity. Innate immunity, how we react to viral infection. If you have a vitamin D, especially more than 30 microgram, then your ability to fight the virus better. That is the meaning of it. Now, what about the neonate and the baby? With regard to the prematurity, Ali mentioned the prematurity more than 50%. In that case, you need to give for lung maturity, in addition to, remember, very important, neuroprotection. You have to give magnesium sulfate for neuroprotection. With regard to neonate, no evidence that the virus will be, like Ali mentioned, that vertical transmission, but no proven vertical transmission. And therefore, breastfeeding is recommended by the WHO, but you have to tell the mother and educate the mother, do not touch and cover her face with mask, wash, and all these precautions in order to prevent any transmission from the mother to the baby. Now, escalation to the ITU is very important. One thing that I should tell you that you have to stay at home. Otherwise, you will be intubated by a gynecologist, which we don't actually need to do that. Now, with the ITU, the main education here is early intubation. Early intubation is very important in order to avoid deterioration of the lung function, in addition to other intervention which I mentioned earlier. Nowadays, we're talking about how the American bought this remdesivir, and this is antiviral drug. Antiviral drug, you give it daily when the patient, if you have a patient with mechanical ventilation or on ECMO, you give one loading dose of 200 milligrams IV infusion, followed by 100 milligrams every day for 10 days. But if you have a patient, but no need for mechanical ventilation, you can give it for 5 days. If there is no improvement, you can actually extend it to 10 days. Remember that the cost of the production of the drug is $2, but they are now providing it for $2,000 for patients for 10 days. That's a lot of money. Now, remember that you have to look after yourself. Mental well-being, looking after yourself. Work as a team, avoid social media, take a break, eat well and healthy, keep communicating with family and friend and colleague, talk about difficult cases, and engage in any activity which will take your mind away from COVID. Now, we are very lucky that the airline, the British Airways, EasyJet, Ryanair, they actually open cafe in our hospital. And you can go there and you enjoy and relax, and they will provide you with food and drink and coffee and tea, like you are actually sitting in an airplane, which is very good because then you can actually relax from COVID. Outcome, we know the outcome. The Italian mentioned that the death rate from COVID is about 9%. The Chinese mentioned the death rate is about 2.3%. So variability depending on the population, and that we know very well. Now, however, the question now, the situation is evolving daily. Evolving daily, every day we have different talk about COVID, different drug, effective drug, but still we are not actually there for the accurate or specific treatment of COVID. What about the future? We have to prevent another viral pandemic. How? Reduction of the interface or interaction between human and animal, that's very important. Biosafety and biodiversity, very important. Monitoring livestock movement and try to separate the livestock, the animal from each other. And of course, development of vaccine, which should be international effort rather than one nation doing that for financial gain. And thank you very much for listening.
Thank you very much, Ustad Rahim. And that's mean that we should ask China to stop that communication with animals to protect us.
Not China only. We will come to that in question and answer. But no, it's nothing to do with that. But it could be any animal, and there are many theories now. But we'll talk about it later on.
Next presentation will be for Dr. Ala. Dr. Ala is assistant professor in the Khar Medical College, Bint Al Huda Teaching Hospital. Now the presentation for Dr. Ala. Welcome, Dr. Ala.
Okay.
Dr. Ala, please loud your voice. The voice is not clear.
Thank you, Dr. Manan. Okay, great thanks and attitude for everyone for giving me the opportunity to participate in this webinar, especially College of Medicine, University of Karbala. And let me to echo the word of thanks and gratitude to my teacher, Professor Rahim Haloub and Professor Ali Naqash, since I'm postgraduate. Thank you for everything you have given me. So I speak with COVID-19 in pregnancy, which is the latest son of coronavirus, as Dr. Ali Naqash said. Next slide, please. Next slide. Hello?
The slide is here, Dr. Ala.
Okay, next slide, please. COVID-19 infection in pregnancy. So I speak about 34 years old woman, previously healthy, at 38 weeks gestation. She's gravid 2, para 1 cesarean section before 2 years. The previous slide, Dr. Haider. Okay.
Yes, it is. It is the first slide.
Due to breech presentation
Okay.
since 2 years. She gives history of dry, irritative cough, fever, myalgia, and experienced shortness of breath for 8 days before admission. She consulted Al Hussein Teaching Hospital when her symptoms become so worse. Next slide. Next slide, please.
Yes, it is. We have the slide on arrival.
On arrival, okay. On arrival, examination, full history was taken and thorough examination was done. She experienced shortness of breath, her SpO2 84 and respiratory rate 33. Her temperature was 39 and she's normotensive, blood pressure 110 over 50 millimeter mercury, and the pulse rate or heart rate 125. On arrival, CT of the chest, typically viral pneumonia, bilateral consolidation, and nasopharyngeal swab was taken and has a positive result after 8 to 10 hours. Antenatal fetal well-being done in form of ultrasound, which reveal single viable fetus, breech presentation 38 weeks. Biophysical profile 8/8, excluding non-stress test. Complete blood count was done and revealed her hemoglobin level 10.5 and white BC count 7,000 with marked lymphopenia. Her platelet count 340. Biochemical test for random blood sugar normal, renal function test, urea and creatinine normal, and say patient so Dysnexo sent for LDH, which 900, serum ferritin 1,800, and D-dimer 2,000. Next slide. Supportive treatment was given in form high flow O2 therapy, intravenous antibiotic in form of meropenem, and IV dexamethasone 6 milligram once a daily, and paracetamol infusion, and enoxaparin 4,000 international unit by 2, and Nexium vial 40 milligram by 2. Vitamins, and after 4 hours, patient developed intermittent hypoxemia and put on CPAP list. Then Patient developed labor pain, spontaneous labor, and bloody vaginal discharge. Next slide, please. Next slide. Then patient referred to Bint Al Huda Teaching Maternity Hospital. On arrival, she's conscious, oriented, heart rate 132, respiratory rate 35, also normotensive blood pressure 110 of over 50, and her temperature 39, her SpO2 72. Presented with labor pain, heavy show, 4 cm cervical dilatation, 50% effacement, breech presentation, -3 station, and rupture membrane, thick meconium. Her fetal heart rate 165. All measure was taken. They call us before the patient referred to us, and all measure was taking personal protective equipment for all staff, minimal staff available in the second theater, isolated theater. Supportive measure was given by anesthetics and his team, spinal anesthesia and symptomatic treatment. Elective underwent emergency cesarean section was done, an eventful procedure. Result, single viable female baby, weight 3.6 kg and Apgar score 10 in 5 minutes. Next slide, please. Post-operative close follow-up, patient developed intermittent hypoxemia, auto-saturation 69 up to 72, need ventilatory support, so refer to RCU day 1 post-op and put it on non-invasive ventilation. 24 hours later, patient acutely decompensated, intubated, and all measured treatment was given. Unfortunately, despite maximal ventilatory support, she had cardiopulmonary collapse and died within the 48 hours after failed resuscitative effort. She died, leaving her 2 daughters alone with moderate to severely diseased father with COVID-19 infection. And this is at the first of the problem. Now, our pregnant lady coming so early, presented with mild to moderate symptom, and informed the health professional or outpatient persons about her problem and treated, and now little bit better. Thank you very much.
Thank you, Dr. Ala. This is a very sad story about COVID-19 in pregnancy. And the next case presentation will be for Dr. May Saloon. Dr. May Saloon, Adnan lecturer, obstetric and gynecology in Karbala Medical College, University of Karbala, consultant obstetric and gynecologist. Now she has a case presentation. Welcome, Dr. May Saloon. Can you unmute yourself, Dr. May Saloon?
Okay.
Okay.
Thank you, Dr. Manal, and thank you for all of attendance. They are permit us to such meeting, which is nice meeting, and discuss very important subject nowadays, which is the coronavirus infection in pregnancy. My case presentation is a coronavirus in pregnancy. Okay, next slide, please. Or COVID-19, I have a case presentation. Dr. Haider, next slide. Okay. My patient was 35 years old, and she's gravida 5 para 4, abortion 0. All of her previous deliveries by cesarean sections. Her previous deliveries was previous 4 cesarean sections. We presented to us with a labor pain, and she was referred from the infectious ward of Al-Imam Al-Hussein City Teaching Hospital. She's a referral case. She was diagnosed 14 days before she's admitted to us as a case of COVID-19 with the classical symptoms of fever, cough, shortness of breath, and her PCR for COVID-19 was positive. Next slide. Next slide, please.
دكتورة ميسلون, the slide is changed. Then admitted.
Yes, but it does not change with me. Yes, it is changed. Then then she's admitted in our hospital, which is the Karbala Maternity Hospital, in a special ward, which call it Al Shafa ward. It is isolated ward special for COVID-19 cases. We opened a file for her, complete history with the clinical examination we did. Her vital signs, all of her vital signs were normal. Her oxygen saturation was normal. She has no shortness of breath. Her respiratory rate was normal. When we did a PV examination for her, the cervical dilatation was 2 centimeters, soft cervix and midline in position. Next, please. Yes, we did for her a CTG with a baseline obstetrical ultrasound, which revealed a single viable fetus of 38 weeks by femoral length. Her lower segment thickness was 5.5 millimeter in diameter. The placenta was fundo anterior, not previa, with positive uterine contractions in the anterior wall. CBC also done, which is normal, with cross match and 1 pint of blood prepared for her. Virology screen, which was negative regarding HBS, HIV, and HVC. Consent did to inform the patient to do a tubal ligation, but she's refused. All measures were arranged for emergency 5th lower segment cesarean section. Yes, then cesarean section, we do. All of the attendants wear the PPE before entering to the theater room, counseling the patients by senior consultant about the operation, reassure her that all of things are arranged and there was no harm on her regarding that she had a coronavirus infection and she was stable. The teamwork were included 5 persons only. The operators, who are the senior consultant with nurse assistant, an anesthetist team, specialists with anesthetist assistant, or senior house officer controller. Next slide, please. Okay, next slide. Dr. Haidar. Okay, this is the operative room, team. Next, this is the anesthetist team. Okay, next. This is the operator, yes. Next. Next, please. Okay, spinal anesthesia was given for her. Lower segment cesarean section did. The outcome was a live male baby active of average birth weight, blood loss average, hemostasis secured by stitch ligature, suction used, no cauterization used. Then the patient transferred to the room beside the operative room, which was prepared for patient with COVID-19 during pandemic period. Next slide, please. The patient was fully conscious. All of her vital signs were normal, normal breathing, normal oxygen saturation. After we finishing the operation, all members in the team exchanged their clothes, which is the PPE, in the same room that they wear their clothes, as they can take the optimal measures to avoid infection. And the next day, the patient fully mobilized, good urine output, average blood loss, vaginal blood loss, start breastfeeding, took oral fluid, and she received parenteral antibiotic with analgesia. Next. Continue. Regarding her protocol for COVID-19, she did not receive any treatment apart from paracetamol injection twice daily in addition to tonics. Then the next day, after 24 hours, the patient returned back to the infectious ward, life ward in Al-Imam Al-Hussein City Teaching Hospital. Now the patient was in her own home and she was discharging from hospital with good general health. Just I need the recommendation, Dr. Haider, إذا ممكن. Number one, all pregnant women with COVID-19 should be admitted to special isolated ward with full equipment and protective measures was prepared for either vaginal delivery or cesarean section to prevent infection with COVID-19. Number two, all pregnant women with COVID-19 should receive spinal anesthesia better than general to decrease the spread of infection as much as possible. Number three, all medical staff should be informed well risky because they are more exposed to infection should advise them to do frequent checking for early detection for infection in order to decrease the spread of infection and to prevent complications that may face them during infection with COVID-19. And thank you very much. And I am sorry for this delay.
Okay, thank you very much, Dr. May Saloon. Thank you for your nice presentation. Now the next lecture will be for me. And yes. I will share my lecture now. Okay, my case presentation is about this case. Next slide, please. This the first of 2000 update presented in my clinic, and this lady in her antenatal care, because of pregnant lady, they fear from antenatal care and go to the clinic and from getting the infection. So she has a poor antenatal care. She consulted me in my private clinic as she has labor pain. She was irritable and counting from pain. Her blood pressure was about 110/70, and her birth rate is about 108 beat per minute. The uterus was contracting. PV examination showed 1 centimeter dilated cervix, and it was not a phase. And the patient had a fetal tachycardia. The patient mother-in-law were very upset because the general hospital discharged her home as she was still in the latent phase. For that, I looked her for a private hospital for CTG and vital sign observation to exclude placental abruption, because the patient, when presented to me, she had a contracting uterus and she was very irritable, and because of the fetal tachycardia, because the patient had a tachycardia, I was confusing first, as the patient, she had serious things rather than labor pain. Okay, after 1 hour, I received a call from the hospital. The patient reached the hospital, and the CTG done for her. The doctor there, she informed me that the contraction was about 1 to 2 uterine contraction per 10-minute observation, and the fetal heart, basal fetal heart, is about 160, normal variability, no deceleration, and no sign of fetal distress. Just there is fetal tachycardia from time to time, and the patient still have a tachycardia, but her temperature is increasing, and she gets about 38.5 degrees centigrade. And the patient claimed, because the doctor there start taking history from the patient to find out what is the cause of that high grade temperature. She claimed she has a watery vaginal discharge from time to time. And this patient was very irritable and shouting from pain, and she asked frequently for cesarean section to end that pain. Okay, next slide, please. On my arrival to hospital, I did a sterile speculum examination, and I think that's the cause of that fever is coming from leaking glycer, as the patient claimed. And she said that there is a leaking glycer from time to time. But she will have a dry vagina, and I asked the patient to cough frequently. She have a dry vagina and no any leaking glycer. But the patient, she was very irritable when I did the speculum examination. The cervical examination was unchanged, and the patient still have high-grade fever, and the temperature reached 39.0 centigrade, despite the cold sponge and paracetamol that is giving intravenously. CTG was normal, but sometimes she developed tachycardia in food, but where the temperature mildly reduced with cold sponge and paracetamol for only a few minutes. She then developed severe headache and running nose, and abdominal pain subside. For that, I asked the medical consultation to exclude COVID-19, so that the patient was confusing when she for diagnosis when she arrived to the hospital. In the hospital, we did also an ultrasound and Doppler study to find if there is a fetal problem. Everything was normal, and we asked the patient for medical consultation, but the patient refused. When she feared from COVID-19 and that that they may diagnose her as a COVID-19, she feared that they will isolate her from her family. So she refused the medical consultation and discharge on her responsibility. Okay, next slide. Next slide. Okay. دكتور حيدر.
نعم دكتورة، احنا على الاكسل شيت.
The investigation which we did for this patient, which now you can see it on the slide, was most of them not caused with coronavirus, and the patient have leukocytosis. For that, we still confusing because of she has high white PC count, and the patient may still we were query about that the patient may have another problem, may have ruptured membrane or leaking glycer, or may have get infection other than coronavirus. So that we did an ultrasound on Doppler study. Yes, next slide. Next slide. Okay, next slide.
حاليا احنا على الهيباتيتس سي دكتورة.
Okay. Okay. Next slide, yes. Okay. In the night, in the same day in the night, the patient develops severe dyspnea. That is when the patient discharge on her responsibility and go back for her home, and generalized bone ache and high-grade fever, and the same symptom occur in other member in her family. And for that, they all admitted for Al Husseini General Hospital, and there they all was diagnosed as COVID-19 infected family, and that they did for their nasal swab and confirmed by CT, but the patient said that CT didn't done for her because she was. Next day, I received a call from the hospital about the patient condition, and but I didn't know, so that I examined her and did the investigation and stayed for a long period with her only by a simple mask without appropriate equipment with me and the nurse and the doctor on call. We were around her, and the patient, actually, she was very nervous and very mask, refused to wear the mask, and she was shouting if we start to advise her for any protection or any advice. The patient stayed in the hospital for about 1 week on Al Husseini Hospital on a CPAP. and observation. She said they gave her frequently antibiotic and paracetamol, and she was very worried about if that paracetamol and antibiotic may harm their fetus, and she frequently called me, is okay, will my baby be okay, will all these medication giving to me. Then she gradually improved, and they transferred her to another hospital, which was very distant from the city, for just observation and isolation, and give her O2 by mouth and follow up. And she stayed there for about another 2 weeks. Next slide. In that hospital, there was no obstetric unit. The patient became post-date, felt no fetal movement for about 3 days, and she still had attacks of severe dyspnea, mostly at night. The patient for that transferred for the maternity unit for counseling obstetric opinion. The distance from that isolation hospital, from the maternity hospital, is about 30 minutes, but because of the traffic and because of what they did to stop the crowded on the road, she take about 1 hour and 30 minutes to reach the hospital. Abdominal and pelvic examination when she reached the hospital was done for her. She had unfavorable cervix, a big size baby. On the ultrasound and Doppler study was all normal, reactive CTG, and the patient returned back to the observation hospital at the same day because she had no problem. Okay, next slide. Then after two days, I got a call from the hospital manager as the patient asked to follow by me. I discussed with my colleagues the line of her management and decided to do a cesarean section. Why cesarean section? To decrease the risk of exposure to the staff, and because we have a limited PPE in the hospital and high risk of induction failure. For that, we decided to do for her a cesarean section. Okay, next slide. Cesarean section done for her under effect of the spinal anesthesia. She delivered about a 3.8 kg male baby, healthy baby. But next day, he became lethargic, poor feeding, and developed jaundice. Now the patient improved, and she kept in her own house. The baby also improving, but still the patient had dyspnea when lying supine and the attacks of distressing dry cough. And also the patient, she breastfed her baby, and she did all the protection in order not to infect her baby from her breast. Future lesson. The first presenting symptom for COVID-19 infected patient, pregnant patient was very confusing as abdominal colic, high-grade fever, fetal tachycardia. This may give many differential diagnoses. So in pandemic, we should raise the index of suspicion of infection to prove otherwise. This is my opinion. And next lesson is we need a multidisciplinary expert team in COVID-19 infection and in pregnancy with all equipment needed like portable ultrasound, CTG, senior midwife should all be available for COVID-19 infected pregnant women in the isolation group. And we need a clear guideline suitable for local hospital and is of available facilities to manage the patient with COVID-19 pregnant patients. Okay, next slide. This was the cesarean section. Next slide. Next slide, please. That is the baby. He was a very big baby for prime gravida lady. Okay, next slide. And that is what my team during cesarean section, the anesthetist and the pediatrician and me, and with all PPE equipment in the theater and in the book. Okay, thank you very much. Thank you for all the speaker, and if there is any comment about these cases we presented for them, and if anyone want to interpret and to give us any opinion about these three cases from our speakers. Dr. Ali.
Yeah, I just want to ask Ala about the her patient. I think probably either Ala or Maithlun about the anterior placenta, and she had a previous section, and I'm not sure whether they thought about the acrita at that time.
Maysaloon, I think. Dr. Maysaloon?
Maithlun, yeah.
She has a previous post cesarean section. Dr. Maysaloon, can you join us? Dr.
You
Maysaloon?
hear me?
Yes, yes,
You
we
hear
are.
me?
Yes, we are,
Yes.
Dr.
Yes. No, she's not acrita. She's fundo anterior placenta, not previa. We did just cesarean section. You hear me?
We hear you loud.
Yeah, now we can hear you.
Yes.
But no, the question about the
Yes,
remember
we are
that-
hearing you.
yeah.
وين كان صوتك ختلان؟
Well, we are actually questioning about the
دكتور علي العفو، وهي
anterior
بطويريج دكتور
placenta.
علي،
لازم
وهي بطويريج مسافه بين طويريج وبين كربلاء.
اي هذه بالضبط يس هيك.
Yeah, anyway, that's my question. Don't worry. I mean, you are okay then. Everything fine. Done all right. Yeah, good. And one other question to Dr. Ala about her patient. I think the deterioration of that patient is very, very quickly. And I'm not sure why the patient went from the oxygen requirement very minimum, because she was using the NIV, which is non-invasive ventilation, to intubation to death. So what happened actually? I'm not sure what happened.
Of the patient coming with the SpO2 saturation 84 and put it on high flow oxygen, then become better. Then intermittent hypoxemia, put it on CPAP list. Then patient develop labor pain and refer to our hospital also on non-invasive ventilation. The oxygen become high and intermittent hypoxemia. Then referred to RCU and intubation. All this story occur within 14 hours.
I think what happened, in my opinion, I'm not sure whether you would agree with me, that probably that was late intubation. The patient should be intubated early. Early intubation will actually save a lot of life. And the fact that her saturation was very low, 84, of course, when you reach 90, you have a problem. You have a problem, and therefore, our cutoff for intubation is 92, and therefore, if you delay the patient more, meaning that you will have more complication, more hypoxia, and there are a lot of metabolic changes, which might actually lead to multi-organ failure and death, of course. So therefore, probably that might be due to delay intubation. I think, in my opinion, I'm not sure about what happened exactly. Thank you.
And invasive ventilation and O2 saturation become high. So no problem. 96 on non-invasive ventilation, then develop sudden deterioration, intermittent hypoxemia, then intubation was done, decompensation, acute decompensation after that.
Yeah.
يعني شنو هي died on the table while the cesarean? How she died?
No,
No, died after Ali.
died after
Yeah, after section. The problem, there are two problems with the intubation. If you don't intubate early, you will have a problem because the damage done. Remember that our understanding of COVID effect on the lung is different now. We thought that it's the inflammatory process affecting the lung. Now the question is the microemboli and formation of the, it will interfere with the blood flow in the lung and in other tissue. And therefore, prevention of the microemboli formation is very important. Therefore, early ventilation. But occasionally, people might actually recover and the tube removed, and then they deteriorate because the tube was removed early. And therefore, prolonged ventilation might be better actually than removing the tube early. Some people might actually go back to the ward for recovery, but then they deteriorate after 24, 48 hours and then go back to the ITU. When they go back to the ITU, it's too late. They will continue on the ventilation, but the probability of death here, dying, is very, very high. And that's the problem.
العفو دكتور علاء، انتم استعملتوا عندها كان اون هابوين ثرومبوبروفيلاكسيس والسوالف لو ما
She had that.
By two.
Very severe case of COVID-19, so we double the dose, as Professor Rahim said. We give double the dose, 4,000 international unit enoxaparin by 2.
العفو استاذ رحيم، ممكن مداخله؟ العفو.
تفضل عيني.
طبعا رحب بكم مع الدكتور موسى، يعني
يا هلا دكتور، مرحبا عيني.
الله يسلمك. بس في شيء واحد ممكن كومنت باي ذا واي على الكوفيد 19. احنا لازم يعني صراحه، هو لانه الايفنت حديث والان في طور الستدينج والدراسات والبحوث، لكن انا تعليق عندي على موضوع الانتوبيشن وعلى موضوع هواي اشياء من زملائنا الانترفست اللي الار سي يو يشتغلون. هواي اشياء لازم نراجعها، مثلا نراجع قناعاتنا بها، حتى البلازما تريتمنت، حتى هاي الريجيم اللي يعني احنا بدنا نشتغل على شيء جديد لسه ما مكتشف. حضرتك هسه قلت ممكن انه الانتوبيشن لازم يكون ايرلي ولازم يعني يظل فتره طويله، لانه ممكن يسوي كومبليكيشن على اساس انه يتحسن وبعدين يرجع. فانا اعتقد لازم تنحط الان، احنا كلنا في طور وضع بروتوكولات جديده لهذا لكل ما يخص عمليه العلاج الكوفيد 19. اعتقد لازم نراجع الاشياء اللي احنا متعودين عليها على الانفكشن او على الاشياء اللي احنا اصلا متعوديها، الار سي يو وغير الار سي يو والجايد لاين اللي نشتغل عليها، لازم تراجع كلها مره ثانيه. اعتقد
دكتور مثنى شكرا عيني. انا الحقيقه I mentioned a few things about the O2. O2 management is very tricky, and we have to understand what the meaning of it. When we are breathing, we are only requiring 250 ml. When you put a tube for general anesthetic for a normal patient, you require only 300 to 400 ml. It means very minimum to reach saturation of 98 to 100. Okay, but when it comes to the COVID, your requirement it jump from the 400, 500 to 10 to 12 for 15 liters, and that's huge. Why? Because the lung is damaged, and the exchange of gas in the lung is very, very minimal. Therefore, you have to push very large amount of oxygen to the lung in order to get a little bit of oxygen into the blood and into the tissue. So therefore, that's the problem because of the microemboli. And the microemboli and that it reflects actually on the D-dimer. If you look at the D-dimer with COVID, you will have a D-dimer way above 1,000, sometimes maybe 5 or 10,000 D-dimer. Although the D-dimer is not actually very good in a pregnant woman because it's very difficult actually to judge. However, if you have a very high D-dimer, it actually indicates that the effect of the microemboli on the patient and the damage to the tissue is very, very high. And don't forget the intubation itself is a problem. because the long-term problem with the intubation, especially if you require intubation for a long time, you might actually have a problem, tracheal damage, bronchial damage, and sometimes you might actually need to remove the tube and do tracheotomy. And that will actually give you a problem of changing the tube, maintaining the oxygenation, preventing infection to the people doing it because of the what we call it the AGP, which is the aerosol generating procedure. So therefore, we are actually learning, as you mentioned, we are learning about the condition, and until now, not everything is clear. The management of the COVID in March, April, different from the management of COVID now, because the pathology is not very well known in March, April, but now the pathology is completely different. Before we think that fibroid, now we think that it's microemboli. That's why the VTE, the prophylactic measure to give like heparin or whatever, it's very important. And to give early rather than late, to give dexamethasone rather than late, all the management should be timed.
يعني دكتور موسى انتم الانيستاتست يعني انتم تجتمعون بها يعني هاي كلها انيستاتست فيلد يعني انت كاوبستريشن يو كانوت يعني تجتهد بهاي القضايا فانتم الانيستاتست they have to have their share of the burden يعني هاي شغلات احنا عندي واحد صديقي ENTist يقول لي في one night he is ENTist he had to do 5 tracheostomies for the anesthetist. يعني انتو how many you anesthetists how often they do the tracheostomies?
دكتور العفو دكتور علي هم تدري الموضوع حديث والان هم يعني اوفر بيردين بالشغل يعني ما يلحقون اصلا هسه يعني نتواصل وياهم ونشوف نشتغل وياهم خاصه هم مركزين بالكوفيد 19 يونتس عاده اليونتس اللي الانتنسيف يونت هم الان موجودين يعني من يصير هيك حدث هسه زميلتنا دكتوره ميسلون ودكتوره منال سووا سيزاريان سكشن بالستاف العادي مالتنا اللي اصلا ما مشتغل يعني هاي الاشياء السابقه.
هاي المشكله زين انتم عندكم كوفيد ليت have a cesarean section. انتم at least tell the ITU people especially the one you think she is severe case يعني حتى ما يجي الجونيور خطيه هذا البيرمننت يقعد توقع براسه وانت you have to ask him to do this maybe he hasn't done this before يعني you don't blame him بيني وبينك فانتو you have to get the anesthetist involved with you يعني لا تاخذوها كلها على عاطفكم وتقعدون لانه this is completely different science اخي completely different science ITU anesthesia different science.
كلامك مضبوط صحيح دكتور بس هي هاي قلت لك يعني احنا دكتور احنا قلت لها قلت احنا لازم هواي نراجع البروتوكولات مال شغلنا هواي مره ثانيه لازم نراجع.
لازم بحثكم ولازم تجيبوهم تقعدون وياهم وتقول لهم يابا هاي الكيسات اللي we lost them because this we have to do this يعني اكو احنا حتى هنا يسموها obstetric anesthetic meeting يجمعون الاثنين they sit together they talk together obstetric anesthetic meetings حتى they have international meeting like that. هاي أهمية الشغلة يا أخي مو إحنا ناخذها على
Can I interrupt Ali? The problem Ali is the guideline and protocol. It had to be joint protocol. Not only just the meeting, but the joint protocol for everyone to know about it and therefore to go by it. So therefore you know how to communicate with people, you know where to go, you know who to call. All that kind of thing should be actually written in the protocol agreed between the obstetrician and the ITU people. It's a multidisciplinary approach and even medical people also.
صحيح بس الشغله البروتوكول يعني البروتوكول يتغير البروتوكول التشاينيز يتغير هسه
طبعا. I'm not talking about the protocol of treatment. I'm talking about the protocol of management, meaning that where to put the patient, where to go, which part, and how to do it. And that's the thing. That's a common thing.
تعرف أنا أحكي لك شاي دكتور موسى هنا بالبداية الأيام الأولى تقريبا بالنص مارس جت علينا السيستم مال ليبر وورد يسوون ريهرسل how do they push the patient to theater, a COVID patient? This kind of the preparation they do. من هنا نجيب الشرباية، من هنا تدفعها، من هنا تحط هذا، من هنا ما ادري شنو. فهاي kind of small details. يقول لك لأن لما تصير الخبصة بنص الليل ويصير البانيك ذاك الوقت you don't blame the staff to make mistakes لأنه there is no plan. فهي سوت لهم مثل bold letter فد letter هالكبرى علقتها على الحائط. If you have a COVID delivery at night, you do these things. 1 2 3 4 10 نقاط. يعني الأعمى يندل. فذاك الوقت انت هذا المقيم المسكين الساعة 2 الصبح اللي يريد يسوي emergency cesarean section. هذا you don't blame him إذا خبط وتجي له كوفيد ليت.
يعني هو هذا اللي نقوله، هو هذا الجايد لاين، هو الجايد لاين مو شرط فد 20 ورقه، الجايد لاين حتى فد شيت موجوده على الحائط، هو هذا جايد لاين.
انا اتذكر صار نقاش كله على مود انه هاي الشربايه ما لازم ما تطخ بالحائط هذا، لان هاي الشربايه اذا طخت بالحائط هذا الحائط going to be dirty wall لهالدرجه يعني هم they are particular about this thing.
Yes, you are right. We need a protocol, and that is what I mentioned in my lecture. We need a protocol, and it should be suitable for our equipment and the facilities.
Not on your own. You bring the midwives and you bring the anesthetist.
Yes.
You need all of them together. You don't take it on your own as an obstetrician. So if things go wrong, you think I am only responsible. No, it has to be the midwife with you. وتعلمين الميدوايف وتسوي لهم clear instruction بالكلمات الكبيرة الواضحة وتلزقيها على الحائط. حتى لما يجي الليل المشاكل كلها تصير بالليل، نص الليل 3 الصبح، حتى تكون الشغلة جدا واضحة، تكون درب الأعمى. Anybody can just follow the orders.
Yes. Okay, now we will start to answer the question for the question and the answer in the bar. Okay, Dr. Haider, can you help us and show us the
I have answered by writing nearly 35 people. I have answered 35 people.
Yes, I see that.
Yeah.
There is a questions that we answered by Dr. Ali, and the rest of the question, Dr. Haider, can you show us?
Dr. Ali Mohsen, our medical manager, will start Q&A, start asking our guests.
Yes, okay, Dr. Ali.
Okay, can you hear me?
Yeah.
Yes, sir.
Okay, so I shall start with the important questions. Starting with a question, what's the effect of COVID-19 in patient post-operative surgery, especially cesarean section? Dr. Masar Al-Husseini, she didn't specify to which speaker was the question.
نروح على كبير القاعدة. يلا رحيم.
أنا الحقيقة ما افتهمت الكويشن شنو هو.
What is the effect of COVID-19 in patients post-operative surgery, especially cesarean section?
That's a very good question. In fact, when you deliver the baby, it will be a general management of non-COVID-19 or COVID-19 not pregnant women. So therefore, the management of the patient after delivery will be the same like management of any other patient with COVID. So therefore, like Dr. Ala mentioned about the delivery of the patient and how they manage her after delivery. So therefore, intubation will continue or the treatment will continue according to the general measurement. So therefore, there is no specific thing about that apart from the if the patient is breastfeeding, therefore you need to take that into consideration with regard to the baby. But there is no other specific management.
Okay, another question for you, Dr. Rahim. Was the indications for admission in COVID group and the control group in the study you mentioned identical?
Yeah, it was identical. It was American publication. The American publication looking at any admission to the hospital, any woman, non-pregnant or pregnant woman with COVID-19. That means indication to admit, an indication to admit to the ITU. So therefore, it will be universal indication. And then they compare the non-pregnant with pregnant women. Yeah.
A question from Dr. Karim Aziz. Have we standard and update protocol in our hospitals to deal with COVID-19? I think he means Iraq hospitals. And I think this topic was covered sufficiently in the presentations. So would you like to add anything, Dr. Rahim or Dr. Ali?
Well, we agree, me and Dr. Ali, about guideline and protocol. And remember that the protocol, if you go to the website of the Royal College updating the knowledge about COVID every week. So therefore, the protocol we start in March does not actually mean that we continue on that protocol in June or July. But therefore, every week we are updating our protocol.
Many questions, actually, 4 to 5 questions, are asking about the dose of supplements, vitamin D3, vitamin C, and zinc in a pregnancy lady with COVID-19.
I didn't actually mention a thing about the vitamin multivitamin. I mentioned that people will take multivitamin anyway to improve the immunity. But with regard to the vitamin D, I mentioned the study about giving vitamin D 10 microgram, 20 microgram, 30 microgram, and 40, and the effect of that dose on the acquiring and reacting to the infection with COVID-19. And it clearly indicated that if you are taking the 40 microgram, the likelihood of acquiring the COVID-19 and having a mild form of it rather than a moderate or severe one. So therefore, 30 to 40 microgram might be giving you protection. And I mentioned that the effect of the vitamin D, anti-inflammatory or decrease the inflammation, number one, and number two, it will improve your innate immunity. That means your reaction to the infection will be different, and therefore you fight the infection in different way and a better way. So therefore you will acquire the infection, but you will have mild form of infection rather than a bad one.
I can add something to this, the zinc vitamin C supplement. We have here these dissolvable tablets. I think the same stuff is in Iraq as well. You need 2 of these a day. Each one, I think 1 gram. Anyway, that's what I do myself every day. That's what for a pregnant lady as well, because pregnant lady as well, they need shielding. So at least قرص واحد من دول الحبوب الفوارة I'm pretty sure موجودة بالعراق. من احنا كنا جهاز نستعملها. يعني قرص فوار واحد الصبح وقرص فوار واحد بالليل. هذا اكو قسم منها combination zinc and vitamin C. We have it here. I can bring it here and show it to you if you want me. And let me just 1 second. Let me just bring it. Just 1 second.
Okay. Thank you, Doctor. And meanwhile, there is an interesting question from Dr. Salah Mehdi. What are the recommendations for healthcare personnel who is pregnant, especially if she is in contact with infected patient or suspected people?
Well, they are shielding. They are shielding. If they are pregnant, they should not work. People might say that probably they can work until they are 28 weeks, but the recommendation they should not work. And if they work, we put them in a very low area, low infection area. Therefore, and after 28 weeks, they go home. They are shielding.
شكرا دكتور علي لانه شفنا احنا الكومبينيشن زنك اند فيتامين سي.
هاي موجوده عندكم؟ You provided Asino? Do you have it?
احنا كاسينو ما عندنا بس اتصور موجوده بالصيدليات لانه تيجي supplements in different combination.
هذا 1 جرام the tablet يعني you can take 1 or 2 it doesn't matter حقيقة. ويقول لك the zinc is more important than the vitamin C.
Yes.
But this is a combination one.
Well noted. Thank you. دكتورة نغم الحر تسأل أيضا أوكي vitamin D dose already answered. Dose of vitamin D.
And then the dose of dexamethasone, they also.
Yes, there is a question about the dose of dexamethasone injection.
Yeah, I mentioned that actually. I'm not sure whether that was mentioned. It's 5.3.
A question about the dose of dexamethasone injection.
Yeah. Yeah. I think it's 5.3 milligram. The ampoule of the dexamethasone 3.3. So therefore, you give 2 ampoules every day.
Yes, هو 6 milligram Chinese يقول لك 6 milligram for.
Yeah, about 6 milligram, and orally you take 3 tablets. Each tablet 2 milligram.
There was a nice question by somebody. I forgot. One doctor يقول can we use betamethasone rather than dexamethasone?
No. Definitely not.
Why not?
No, the betamethasone not recommended. In fact, to be honest with you, I don't know. But like you remember, we used betamethasone for maturation of the lung of the baby before. We changed to the dexamethasone because more effective. In addition to that, even the injection, the prednisolone injection, IV injection, it's a methyl prednisolone, very specific.
If it is a case of RDS, يعني any steroid would be effective. صح ولا لا؟
لا مو اني ستيرويد، لا هو فلذلك هو الدexamethasone هو tried and more effective than the other. anti-inflammatory changes and the effect of the, I mean, if you cannot give the dexamethasone, you like in pregnant women, you can actually give IV hydrocortisone. And but nobody mentioned the betamethasone until now.
ويتدري بالعراق الافيلابيلتي تحكم، يعني هو قاعد في مستشفى ما عنده
موجود عيني علي، موجود هيدروكورتيزون، موجود دexamethasone، موجود.
Steroids are available in our hospitals and private.
Available, yeah, available.
Another question from Dr. Zainab Khalaf: was the data available regarding pregnant women with COVID-19 only those from China? Where are the European data?
No. We have data from China. We have data from Italy, which I mentioned. We have data from UK, a lot of data, because we are reporting every COVID to the UK, what we call UCODE. We collected all the information about COVID, and the American actually publish a lot. So therefore, publication is not from China only.
لا دكتورة بس انتوا عليكم you have to have your own data. يعني انتوا you're going to have now a lot of cases. يعني you have to make use of this opportunity. يعني this is an invitation for all of you in all Iraq. بغداد، الجنوب، الشمال. انتوا you have to do your own data as well. يعني هاي الcases اللي تشوفوها whichever outcome end up, whether good outcome or bad outcome, don't let it go without learning the lessons. يعني الكيس مال دكتورة آلاء والكيسات الأخرى مال دكتورة ميسلون، يعني this is an opportunity. يعني أنتوا الآن you have a wealth of data. يعني فالبير مليان بالداتا. يعني this is wealth on its own. يعني imagine how many papers you can do, how many papers you can publish, and you talk in front of other people. يعني this is your opportunity. يعني this is, احنا we facing a problem, But again, with every problem, there is an opportunity. فأنتوا you have to see it as such, as an opportunity to learn and to impress other people. يعني don't let it just go like that and make it just مناسبة للشكوى والبكاء واللطم على الخدود. You have to seize the opportunity, bring the data together, 30, 20, 40 case, bring it together, analyze it, and learn the lesson, please.
Okay. A specific question for Dr. Rahim. In diabetes mellitus patient, the dose of steroid, if she is in second trimester, is it the same?
Yeah, the same. You actually follow the weight of the patient rather than the problem with the patient. But with the diabetic patient, the problem is the implication of giving it on the diabetic, because you have to monitor the blood sugar, and you have to monitor the blood sugar either before or after the food or the eating. So therefore, there's no change in the dose, but there's change in the monitoring. The non-diabetic patient, you do the hemoglobin A1C just to check, to find out whether we have any problem before. But the non-one just mentioned, monitor the blood sugar very frequently, and it's very important to adjust the treatment of diabetes according to that.
Thank you, doctor. There is a question
from... ما ادري اجتني فكره هسه ما ادري سمعيها من العين. انتوا ليش ما تسوون كورونا ستدي؟ Iraq corona study trial. يعني انت liaise with the people in the Midland، يعني انت بغداد people in the north، وتجمعون الكيسات والواتساب موجود، الزوم موجود، فسوي لك local webinar to Iraq about all corona cases good or bad outcome. فراح يصير لكم في حدود 50-70 كيس، يجوز اكثر من هذا. ذاك الوقت you going to make a nice publication تروحين انت و somebody else presented بامريكا بچاينا whatever. فانتوا don't rely just on other people. انتوا you can make your own protocol. يعني انت you are in the middle of it and you can see the
Ali, can I interrupt you, please? There's actually a collection of data in the Ministry of Health. موجودة.
I wouldn't rely on Ministry of Health. Into whatever Ministry of Health, I don't believe their numbers anyway, because I think they.
No, I'm not talking about the number. I'm talking about registration of women, pregnant women with COVID, the death, the complication, all fed to the Ministry of Health.
يسوون a trial. For example, you have now the Russian medicine, the antiviral, Russian. Into you're going to see and you make your own observation. You're going to compare it to dexamethasone, for example, and see which is works. يعني انتوا لا تكونون بس مجرد waiting for other to make you guinea pig for them. يعني هم Russian with Chinese, they want to make you guinea pigs for them. Why do you do that? Until you do your own search. You do your own search.
Sure, yes, but till now we have no lots of number of pregnant ladies here in Karbala in our city. Now we just about delivered just 5 ladies with coronavirus during the pregnancy. But the problem now, if the patient in the antenatal care get the coronavirus, that was the issue. But during delivery, just we have now only 5 ladies delivered with coronavirus.
يعني over the last 3 months, from March.
Yes, over the last 3 months. Yes.
You have only 6.
And 2 of them are suspected only. They are suspected. 2 of them are suspected. They have only rapid test. They have positive rapid test.
Okay.
And the 3 of them, they was proved to have a coronavirus. So that there is no a lot of data about that.
زين انت you look to Najaf. Najaf is only خطوة من يمك. ناصرية يمك. لسان يمك. الواسط يمك. يعني انت بصرة is a big place. Basra is a big place. They have each day now like 170, 180 cases a day. Confirmed cases. فانت liaise with the people in Basra. يعني انت عندك 6 cases. But in the جنوب and الفرات الأوسط يمكن يصير لحد الآن probably 200 cases.
Yes, yes.
That doesn't take much. That only a phone call.
You need coordination.
We
You
need
need
that.
coordination.
We need coordination.
Yeah, indeed. That's very important.
كلكم عندكم موبايلز وما شاء الله كلكم تحبون الواتساب.
Yeah.
ما اسهل منه.
Yes.
يعني نسوي لكم كورونا جروب.
Corona group. Yes, we need that.
اي والله. We invite all specialists from all over the country. فذاك الوقت انتم راح تتصلون باهل بغداد. بغداد now is a big problem. بغداد is a big problem. يعني every day بغداد في حدود 800 case 700 case. Imagine.
Yes.
احكوا يا بغداد هسه انا.
Sure. We have such an idea.
واي من بغداد هسه موجودات ايمان واخلاص وساره كانوا موجودات من اليرموك ويانا. فانتم ليز with them حتى لا يضيع المجهود مالتكم. هاي الاشياء اللي تمرون فيها الالم والقهر والباد كيسي ما تروح هباء.
ان شاء الله.
Okay.
Yes.
Thank
Sure,
you,
this is a good
Professor
idea.
Ali. سؤال من دكتورة شذا سامي. Do you agree to cancel the medical way of induction of labor if there is indication for induction, if the patient was COVID-19 positive, to decrease the time and number of team attached with the patient, since we have shortage in everything in Iraq?
No, هذا الكلام مو دقيق. يعني انت البي بي اي اللي شفته منال لابسته بالعمليه هو نفس البي بي اي الموجود هنا بلندن.
هم يكون واحد. يعني واحد، يعني هو هذا عندنا بس احنا ليميتد، يعني ما نقدر نستخدم اكثر من واحد.
دكتور منال انا احكي لك، احنا in March time when the cases was up to the neck احنا we were working only with a mask in London. يعني هاي البي بي اي اللي نشوفها بالتلفزيون عند تشاينا ما كانت واصله بعدها. وكان ذاك الوقت بلندن البيك each day there is 2,000 cases in UK. فهذا doesn't prevent us from working and from going in. هسه شويه ناس تعلمت قامت تشتري البي بي اي وامازون يبيعها وذاك يبيعها. فانتم بالنسبه لكم يعني انا I've seen a few people around. يعني انتم لا تعتقدون نفسكم محرومين حاليا. عندكم الاشياء والاشياء استعملوها effectively.
Okay.
I think with regard to the question that Ali, can you answer the question then about the induction?
Dr. Ali.
Sorry.
Dr. Ali, can you repeat that question?
Yes. سؤال من دكتورة شذا سامي تسأل تقول do you agree to cancel the medical way for induction of labor if there is indication for induction if the patient was COVID-19 positive?
Why do you cancel it?
هي تقول to decrease دكتور علي to decrease the time and number of team attached to the patient or dedicated to the patient since we have shortage. يعني بمعنى لما عندنا staff shortage can we cancel the medical way of induction of labor for COVID-19 positive patients?
If she cancel her induction, what she's going to do with her? تقول روحي للبيت؟
cesarean section.
أو she's going to
cesarean
section يعني?
Maybe she means that.
She might die from the cesarean section. Very likely. Yes. She might go. يعني why you put patient life in risk just because we think cesarean section is going to be safer? It's not safer. In her case, cesarean section is not safer. She might die. We just heard it. A few cases like that. Very small obstetric anesthetic problem. There is a permanent at the night. Probably he hasn't seen such a case in his life. I don't blame him at all. This lady can very easily go into and lose her life half an hour after delivery. So why do you take such a risk? Unless you have a good anesthetic support, a good ITU service at night, then don't take this risk. Don't send a lady just for cesarean section because you discover she is COVID positive. Don't do that. This is bad obstetric. As simple as that. This is bad obstetrics.
Okay, another question for Dr.
It can be done by the porter, not by a doctor. You are as obstetricians, it's an art. You have to choose the least harm to the patient. And the major harm can happen right now if you, especially with the respiratory problem with COVID-19, we all know about it. This is death afterwards. Yani here, you can very easily deliver her, quick GA or something like that. But what is going to happen after, 1 hour later, after delivery? That's the problem.
Okay. Another question for Dr. Rahim. She said, Dr. Rahim said we should leave the operating room after intubation 20 minutes. How can we do that in cesarean section? And what about the fetus?
No, not leave. No. You should not enter the theater.
Okay.
If it's a GA, we don't actually do it under GA, we do it under spinal or epidural. But if it's a GA, you have to remain outside. You don't enter the theater. After intubation, 20 minutes after intubation, you go in order to avoid any contact with maybe virus floating in the air.
Thank you, Doctor. Actually, another question for me regarding ceftriaxone. What is the possible explanation behind happening of anaphylaxis with repeated use of mesporin in the same patient? Example, after second dose, and this happens with one of my patients, Dr. Nagam Al-Hor تسأل. Actually, Dr. ceftriaxone, like other antibiotics, there is a risk of hypersensitivity reaction. And in the literature, cephalosporins, the prevalence of hypersensitivity to cephalosporins is 1 to 2% of population. Among cephalosporins, ceftriaxone is among the group with lower incidence of hypersensitivity reaction due to its molecular shape and structure. However, there are people with genuine ceftriaxone hypersensitivity, but those people usually present immediate hypersensitivity reaction from the first injection, not from repeated injection as the case you are describing. So probably the reaction may be due to excipients, not ceftriaxone molecule alone. However, in all cases, it is better to perform the skin test before giving third generation cephalosporins to the patient due to a number of anaphylactic cases or hypersensitivity cases that occurred over the last few years in Iraq. And it is better, of course, to give the ceftriaxone by intravenous infusion rather than direct intravenous injection, or by intramuscular injection in case you need to give to the inpatient ceftriaxone. The other question from Dr. Amr Diab, also about ceftriaxone. Is it more allergic or sensitive than amoxicillin? Of course not. The percentage, as I said, for ceftriaxone specifically is less than 1% of the population, and for amoxicillin or penicillin group in general, it may reach up to 5% of population. A question to Dr. Rahim. Do you consider COVID-19 an indication for cesarean section? If not, why the reported cesarean section delivery rate is high in most of the reported articles, around 70%?
Yeah, well, because of the prematurity, we have about 50% of prematurity. Patient come in labor and she's very premature, and therefore people will go immediately for abdominal delivery. The Chinese actually don't allow normal delivery. They actually, any COVID with, remember that we are not talking about COVID because the blood showed COVID. No, we're talking about COVID when the patient complaining of symptoms. She is coming with symptomatic problem. That means she got fever, she got symptom of infection, and therefore, with regard to induction of labor mentioned before, if a patient were coming to you with symptom of COVID, then there's no chance of induction. You go for abdominal delivery. There's no delay, there should be no delay, because what happened is, the more delay, if you put the patient in labor with the problem with hypoxia already, and the labor will actually add another factor which might contribute to more hypoxia, and therefore it will create a problem to the baby and the mother. So therefore, Chinese don't actually do any vaginal delivery, they go for abdominal delivery. However, in our practice, if you have symptomatic patient, then automatically we will actually go for abdominal delivery. And therefore, due to the maturity, prematurity, you will have a very high suction rate.
Thank you, Doctor. Another question regarding the administration method of ceftriaxone, it is for me also. So the Ministry of Health recommend administration of ceftriaxone by IV infusion to reduce side effect. Is this method is scientific and right as a route of injection? Of course, ceftriaxone can be given by intravenous infusion and can be given by slow intravenous injection, and also can be given by intramuscular injection. Another question, I need your opinion about clavuran resistance versus ceftriaxone resistance. Sometimes we hear there is no clavuran resistance, only ceftriaxone resistance. No, actually, both are third generation cephalosporin. However, the spectrum of ceftriaxone is slightly larger than that of cefotaxime. And regarding resistance rate, we cannot just claim that this drug, there is a resistance against it or not. We have to have studies and bacterial resistance patterns to say that. And from the current practice, no, I haven't passed through any clinical study or trials that demonstrated a high resistance rate among ceftriaxone. And I can, yes, I haven't seen such studies. And the spectrum of ceftriaxone is slightly larger than that of cefotaxime. سؤال إلى دكتور علي. In case major pelvic operation, for how long we can give, also for me, a major pelvic operation, you can give it according to the guidelines of the operation itself. I don't know what you exactly mean by major pelvic operation, like hysterectomy or something. In this case, it depends upon many factors, whether the operation is contaminated or not. So you need to follow the guideline regarding the specific type of operation.
There is no need for routine antibiotics. And just because she had a major operation, she should have a routine prophylactic antibiotics. There is no such practice. Nowhere. She has to have routine thromboprophylaxis, but not routine antibiotic prophylaxis, unless there is a sign of sepsis. Yeah, you don't give antibiotics like a sweetie. This is wrong. You know, the risk of resistance would be so high, and no antibiotics would be useful for anybody. Thromboprophylaxis, yes. Every patient who had a major operation, they should have thromboprophylaxis until they are fully mobile, but not antibiotics.
Okay. A question for Dr. Rahim. You kindly mentioned that in case of cesarean section under GA in COVID-19 patient, we should leave the theater for 20 minutes. I think this is a repeated question. So do you mean to leave after intubation? You already have answered this question, Dr. Rahim.
So yeah.
Also, another question for you. Is breastfeeding safe with infected mother with COVID-19, whether symptomatic or asymptomatic clinically?
Yeah. I mean, that's a recommendation of the WHO. WHO recommendation is the patient should be encouraged actually to feed her baby, but to take a precaution. Precaution meaning that hand washing and mask and all that kind of precaution which we do every day. Washing the hand and making sure that everything around is clean and the environment around the baby and the mother is clean. But there's no transmission by the milk. The milk has no viral infection in it. Yeah, it's very encouraged by that's the recommendation of the WHO.
Thank you, doctor. A question for Dr. Maysalun, actually, from Dr. Zainab Khalaf. She's asking, did you do cesarean section for the patient and kept her for 24 hours after that in the ordinary labor ward in the maternity hospital? Dr. Maysalun, you can unmute yourself.
Can you hear me?
دكتور أعيد لك السؤال.
Okay. Yes.
Yes.
Okay.
دكتورة زينب
Dr.
خلف.
Maysalun, we can hear you.
هي موجودة.
Yes.
Okay.
Yes.
Unmute yourself. Unmute, Doctor.
You heard?
Dr. Maysarun, unmute yourself. Unmute yourself.
You hear?
Yes, yes, we can hear you.
Yes. Okay. No, I put the patient in the isolated room in Al Shafa ward, which is a room isolated for COVID-19 ladies, pregnant women, either normal or cesarean section in the same place, not in the ordinary ward. No, at all.
Okay, well noted دكتورة. Thank you very much. سؤال من دكتورة سمية تقول is cesarean section better than normal vaginal delivery for COVID-19 patient?
We just answered that.
We answered it, yeah.
If it's a COVID-19 patient, mean only a lady who was tested and found to have COVID, and she's completely asymptomatic, doesn't have any symptoms, you should treat her for obstetric indication. You shouldn't jump and section. If a lady who's a COVID-19 and symptomatic and considered to be moderate to severe cases, and she cannot breathe, obviously the common sense said you need to go and deliver her. As simple as that. So don't take cesarean section as an easy way out, because this is a risky situation, because you're putting yourself in a problem and the patient as well. If you take it a cesarean section like an easy option, then you can run in all sorts of problems. Believe me. Not most 80% of COVID-19 ladies I've seen in our hospital completely asymptomatic. They go and have vaginal birth. We try them to have a vaginal birth. In fact, when somebody get obstructed and we go for cesarean section, we نشيل قاعة, you know, they have to be moved in a certain way. We have to make sure we don't contaminate theater, we don't do that, we don't do this. So you have to behave the same way. Cesarean section is not like an easy decision to take.
Thank you, Dr. Ali. Actually, أستاذ رياض محمد صالح بالبداية نقل لكم تحياته وسلامه، ويعتب علينا يقول السؤال كان بالأخير. لا حقيقة آسفين أستاذ، هي in the sequence عدد أسئلة كلش كبير. فأستاذ رياض يسأل حضرتك دكتور علي، يقول you said some babies IgM positive. This infected baby, do you think it comes through the blood and the placenta or through the passage through the birth canal?
I don't know. It can be either through this or that, but it's for sure is not coming from the mother, because IgM cannot cross the placenta. No. So it must have been, while the Chinese say vertical transmission doesn't happen, these couple of cases, it says something else. So مو كل شيء يحكوا Chinese معناته منزل من السماء. They're also people like us. They can make mistakes, you know.
Okay, شكرا دكتور. دكتورة نهى حمود تسأل, is a pregnancy regarded as high risk for COVID-19 and how?
I think I mentioned that earlier in my presentation. Immunologically, remember that there are a lot of immunological changes in pregnancy, and therefore she will be at high risk anyway. And that is due to the fact that we have that problem with the pregnant women. There is intervention now. Something, yeah, definitely, no doubt about that. And I mentioned that before in my at the beginning of the presentation. This is due to the fact that there might be due to compression of the lung from the pregnant gravid uterus, in addition to the immunological changes. In addition to that, which is very important, it's the hypercoagulability of the blood. Because we know that the clotting factor increases during the pregnancy, and therefore the likelihood of thrombosis in pregnant women is very high. So therefore, it definitely, if you look at these three factors, definitely she will be at a higher risk. Yeah.
Okay. A question from Dr. Hadil Shok. What about patients who's already on prednisolone during a pregnancy? Is steroid therapy different in dose? I think she means COVID-19 patient, already on prednisolone therapy.
Yeah, no, that's fine. Yeah, that will continue. That will continue, and that's the recommendation. She will continue, but probably the route might actually change. Instead of having it orally, she might actually have IV, depending on her clinical condition.
Okay.
But one thing which is very important, that patient who had inhalation steroid, like ENT patient, then it will be stopped completely, and then she will be given dexamethasone or whatever, and then after recovery or after 10 days of treatment, she will go back to the inhalation for like asthma or other indication.
Another question for you, Dr. Rahim. يسأل, do you think that we have to do classification for patients, mild, severe, or critical ones? So not all patients need to go to hospital, and maybe the mobile team visit them or by online communication as applicable in some countries. So in that way, we can decrease the source of infection.
Definitely, I totally agree with you. China done it, and Italian done it anyway, and therefore not everyone will be admitted. A lot of patients in the community, and they will be shielded, they will be isolated with their family, and that's very well known anyway. But people communicating with them by telephone every now and then to check on them, to check whether they have been deteriorated or not. And once there are indications of deterioration, like temperature, cough, or whatever, then they might actually be called to be admitted. But not everyone will be admitted anyway.
Okay, thanks a lot. And we have the last question today from Dr. Jacqueline Khoshabe. If the patient diagnosed with COVID-19 and full term is an indication for termination of pregnancy, or we can wait according to her obstetric and general condition. يعني حقيقة السؤال صيغته ما واضحة، بس فهمت أنه إذا هي full term.
I think if she deteriorating during a pregnancy, she got COVID-19 during a pregnancy and she started to become deteriorated. This is also we confused about these patients.
You mean she got
COVID-19 during pregnancy and she started to become deteriorated? Can she get benefit from delivery or termination of her pregnancy?
Of course she will benefit from delivery. That's the whole idea. The whole idea is, remember that when you deliver, you are correcting everything in her body. You are correcting taking the pressure from the lung. You are correcting the coagulation. You have a freedom of intubation. You have a freedom of other treatment when the baby is out. So therefore, yeah, definitely, if there's a deterioration, then.
By which route? By which route if she is a preterm? Cesarean section?
Of course, we mentioned that actually, yeah, by section, yeah, from 24 weeks.
Even she is a preterm?
From 24 weeks, you deliver to abdominally from 24 weeks. Yeah, that's the college recommendation, that's the RTOG recommendation.
Okay, this was the last question, and many other doctors from the attendees are giving you their thanks for your time and for your dedication. Back to you, Dr. Manal.
Thank you very much. Thank you all. Thank you for the audience. Thank you for, as you know, and for the speakers. Thank you very much for joining us. And I wish for you a good night and stay safe and away from COVID-19.
I would like to thank Dr. Ali and Dr. Haidar for their efforts. And as usual, they are really dedicated and very good in presentation and organizing for the thing. And thank you very much for everything, for their contribution. And thank you, Dr. Manal, for organizing the forum. And hoping that we will meet again.
عفوا دكتور عفوا دكتورة
تفضلي.
احنا طبعا دكتورة منال يعني باعتبار اني رئيس الفرع فاخركم راح احكي. دكتورة منال مشكورة جدا، وانت دكتورة ميسلون، دكتورة آلاء، وقبلكم الشكر الدكتور رحيم ودكتور علي، وايضا شكر موصول لشركة اسينو طبعا باسم الكلية وباسم الفرع. احنا ان شاء الله ندعوكم الى حلقات نقاشية قريبة ان شاء الله. شكرا جزيلا للجميع.
يبقى الدكتور موسى،
شكرا جزيلا.
بس رجاء من عندي، رجاء من يعني الحكايه اللي قلت عليها مال try to liaise with the south, with the north, with Baghdad regarding COVID patients management.
ان شاء الله ان شاء الله دكتور راح نتواصل ويا الوزاره مثل ما قال الدكتور رحيم. قد ناخذ وياهم، قد ناخذ اللينك وياهم، او قد ناخذ داتا من المحافظات وريبريزنتيف، لان اكو دكتور اكو خليه ازمه بكل محافظه. قد ممكن تفيدنا هاي الخلايا بالمحافظات انه ناخذ داتا من عندها.
كله زين. تعرف هاي it's going to be great paper for you and the department.
ان شاء الله. انا ادعو جميع المشاركين اللي موجودين الان بالمشاركه بهذا الارتكل، اللي ان شاء الله كل الموجودين. احنا الان موجودين من اكثر من محافظه، ممكن نرشح 10 اسماء يشتركون بالبروجكت هذا.
بالضبط. يعني you can publish it in any journal, believe me, any journal you can publish it in, and then it would be a nice for the country as well.
ان شاء الله ان شاء الله.
Thank you very much and good night.
Thank you very much.
مع السلامه.
Thank you.
Good night you all. Thank you very much.
دكتوره منال عفوا بالاخير.
نعم دكتور.
دكتور بس الداتا مال الورشه منين راح نستلمها؟ كلها ريكوردد والحضور وعلى مود شهادات الحضور
بالنسبه لل عن طريق الشركه. هي شركه الحضور.
حقيقه السيشن كله هذا ريكوردد وموجود ان شاء الله اللينك مالته. يعني اكون ريكوست احنا نقدر نبعثه لاي شخص او اي احد من الحضور اللي يريده. زائدا طبعا السيرتيفيكيت اوف اتندنس ان شاء الله راح تكون تندس حسب الايميلات اللي تم بها التسجيل على هذا الويبينار
ان شاء الله. شكرا جزيلا.
وراح نتواصل ويا حضراتكم على مود التواقيع على السيرتيفيكيت اكيد نحتاج.
ان شاء الله. شكرا دكتور علي. شكرا. Thank you very much. Thank you.
شكرا جزيلا. تعبناكم. تصبحون على خير.
اجمعين.
ساعه واحده.
تصبحون على خير. مع السلامه.
تصبحون على خير. مع السلامه.